Okay. All right. Well, welcome everybody. My name is Kay Connors, and I have the honor to be the executive director of the Tagi Madarasi Center for Infant Study. And this is a really special time of year for us where the department invites us to collaborate to host the grand rounds and to have this celebration of our center that started in April in 1982. Dr. Madarasi was a child psychiatrist that opened this center with this seminal symposium with many famous people in the field. It was really the infancy of infant and early childhood mental health psychiatry. And on the right there, you'll see Eric Erickson and his wife, Joan. And so since then, we've continued to really focus on the original mission of the center. I think it's just waking up, where we teach. Dr. Owo told me that that was Dr. Madarasi's favorite thing to do, was to teach. We provide clinical care and consultation in our clinic and out in the community. And we participate in research and other capacity and policy support programs as well. So we learned today that Duke is a very special place to Dr. Madarasi and his family, and our guest speaker is a professor from Duke, and you'll learn about her in a minute. But Dr. Madarasi was a child psychiatrist and an immigrant from Iran. And he trained at McGill University in Canada and then came to the United States and did his residency at Duke University, where he met his wife, Ann Tyler, who is a rather famous novelist who still lives here in Baltimore. And he really is considered one of the pioneers of infant mental health. So it's a pleasure and honor for us to carry on that tradition. If you can stay for lunch and our advisory meeting, you can hear more about the things that we've been doing. But for now, I'm going to pass it to Dr. Sarah Edwards, our division director, to introduce our speaker.
Thank you so much, Kay. Well, good afternoon and welcome, everybody. It is our pleasure to introduce Dr. Karen Appleyard-Carmody. She serves as the co-director at the UC National Center for Child Traumatic Stress. She's a licensed psychologist and associate professor in the Department of Psychiatry and Behavioral Sciences, as well as the Department of Psychology and Neuroscience. Her clinical and research expertise is in infant mental health, child-parent attachment, early childhood trauma and maltreatment, and evidence-based practices to address these issues. She has extensive experience treating trauma in children and families and has contributed to evaluating and promoting evidence-based interventions like ABC and PCIT. Her work also extends to state and national leadership roles, including research collaboration and leadership positions in professional mental health organizations. Please join me in welcoming Dr. Karen Appleyard-Carmody. Thank you.
Thank you so much. Hello, everyone. Can you hear me back there? Okay, great. All right. Hard to tell if I'm going to be loud enough or not. Okay, so I'm going to switch to my slides here. Just want to thank everyone for that lovely introduction. It's really lovely to be honored. I'm really humbled to be invited here today, to be at a place where there's such a long-standing commitment to infant and early childhood mental health. And with this event, pictures for just a second. Also at an event that's honoring the work of Dr. Madarasi. I really can really see through my visit today how much the Center for Infant Study and the work of infant and early childhood mental health is just woven into your Department of Psychiatry, and it's really remarkable to me. I really believe that infant and early childhood mental health really connects many of our goals as psychiatrists, psychologists, social workers, and other related fields. Whether or not we're working directly with an infant or working with a caregiver who is raising an infant, we have an opportunity to really shape the course of development and to intervene and set the course correct when there are things that are going awry. Dr. Motoresi once summed up his work with children and families, and in particular with immigrant families, as saying, the best that you can do is find a foothold and stand with dignity. And I felt like this quote really stood out to me because I do feel like that is something that represents an opportunity for all of us, right, in this work, even in these particularly challenging times, to hear and hold the stories of families with young children, to lift up their voices, to lift up their strengths, and to offer them a grounding and support in order that they can find that foothold and remain resolute and true to themselves as they navigate crises. Here is an agenda. After spending some time talking with Kay Connors and Bree Fellows here, we built this agenda around topics that are of interest to me and are also, I think, really aligned well with the strategic areas of interest and priority that you all have here at the University of Maryland and in Baltimore more broadly. With the hopes of really generating some discussion. Hopefully at the end we'll have some time to do that, or at lunch later. This is the areas that I'll be talking about today. I'll talk a little bit about optimizing and spreading evidence-based interventions, particularly with attachment and biobehavioral catch-up, or ABC for short. I'll talk a little bit about preparing the workforce to assess and diagnose early childhood mental health needs and relational needs. And then I'll talk a little bit about my work as I've transitioned to the National Center, talking about sort of resourcing our nation's early childhood providers. Let me see if this works. Oh, yep, it did work. Sorry, let me go back. Okay, these are the relevant learning objectives, which I think many of you probably received an email about already, so I won't read them to you. And this is just a statement that I have no conflicts to disclose. So let's start with an overview of evidence-based issues in early adversity and how we can intervene to address them. So we know, for example, that stress and adversity are a normal part of the human experience and human development. When we are threatened, we know that our bodies respond in certain ways with a variety of physiological responses, like increasing cortisol or increasing heart rate, increasing blood pressure. Cortisol is released from the midbrain, drives down into the lower brain to kick the body into gear to respond to the stressor that is occurring, right? That's the fight, flight, or freeze approach. And what we know is when a young child especially, is protected by supportive relationships, we see co-regulation occur during those moments of stress. We see that the child is able to learn to cope with everyday stresses, and their stress system in turn responds back to baseline, and the child can return to a calm state right where they need to be to do the things that a young child should be doing, right? So engaging in play, interacting with others, learning. And that's what we really want. And that's when brain development is spared in those moments and can continue to develop well. What we do know is that when children do not have this representation, this buffering of support, we can see some challenges. So let's talk a little bit more about that. When we have a strong, frequent, or prolonged adversity, like separation from a parent, like abuse, or being in foster care, or perhaps living with a parent who has significant mental health or substance use challenges, when those are experienced in early childhood without the support of a buffer, a support of an attachment figure, what we see is that there is excessive cortisol disrupting. We see developing brain circuits not being corrected going in the correct direction. So we see changes in brain architecture. And essentially what we're seeing is that the child is relying on the parts of their brain where they're supposed to be, that's supposed to be focused on survival, as opposed to getting back to that part of the parts of the brain that are really in that calm state, ready to learn, ready to engage. So this can lead to, and also we see that this leads to long-term hyper or even under-responsive stress systems that then over time, as more and more challenges are experienced, that cycle just begins to be repeated. And so what we know is that that can take a toll on development over time. And when this happens, particularly in early life, what we're seeing is that there's a disproportionate impact and lasting impact on the behavioral, emotional, and psychiatric outcomes. So what can we do? What do children look like when they've been exposed to this, and what can we do about it? Dr. Mary Dozier at the University of Delaware found in her early studies with children in foster care and children in the child welfare system that children who have been exposed to this type of early adversity, particularly around the attachment relationship, tend to respond in these three problematic ways. First, they tend to push away their caregivers. That is to say, when they're hurt or frightened or scared, they turn away from the person that they're supposed to be turning to for help. This is seen frequently in children who, when they come into foster care and they have experienced challenges previously, even when they're exposed to a new foster parent, they tend to still show that same behavior of turning away when they haven't been able to turn to those caregivers in the past. Another thing that, and what's important about that really is that what we know is that when that happens and when kids do that, we tend to respond in kind as adults, right? A kid is showing you a signal, and so we do the same thing back to them. And that means essentially that the child is not getting their needs met. The second thing that happened is that children often develop disorganized attachment. So we know that neglected children in foster care have higher rates of disorganized attachment. And why is that important? It's important because we know that disorganized attachment is connected to and related to problematic long-term behavioral and emotional challenges like depression, anxiety, dissociation. Third, we know that, as we just talked about on the last few slides, early adversity affects the stress hormone regulation. So children are learning to regulate their behavior and their physiology differently. And this is important because that means they may not be able to deal with stress as well, or they may have trouble controlling their behavior under stress. And it places them at risk for more psychological difficulties. So what we know from this is that caregivers who are interacting with these children need supports to figure out how to provide the types of environments that can help them with these three challenges. This is an overview of the ABC model, which Dr. Dozier developed after doing that foundational research. It was designed and tested initially for biological parents, foster care parents, and then adoptive parents, originally for kids from the ages of 6 to 24 months. And then it has been adapted since then to reach a higher age from 24 to 36 months, as well as going up the lifespan cycle to work with families who are prenatal to 6 months. It's a very a short model. It's a brief model. It's 10 sessions. All the sessions are video recorded for use later with families to be able to see themselves in action with their kids. And it's a home-based intervention. And what we really feel are sort of some of the key components are that there's very parent-friendly language, there are very engaging activities, and most importantly, there's a live coaching of the parents during these sessions, which is actually sort of the key to making the changes in behaviors. There are 3 and only 3 targets that you focus on when you're doing ABC, and those are 3 here in the middle, really focused on those exact 3 issues that we just talked about, helping kids not to be pushed away, helping them to develop more secure attachments, and helping them not to be frightened so that they can learn to regulate their own behaviors. So we're looking really here at nurturance, following the lead, and not being exposed to frightening behavior. Because when the idea is, as you can see from the conceptual model here, when you have changed these or enhanced these parenting skills, the goal is to be able to see change in later functioning in the child, starting early with attachment quality and early self-regulation, and then in the long term, being able to see inhibitory control, emotion regulation, peer relations, and physiological regulation as they get into middle childhood. And that is what Dr. Dozier's team at Delaware has followed over time. And you can see the evidence here for this really elegantly brief interaction or intervention, but very powerful one, and the different outcomes that it has, with a number of RCTs demonstrating longitudinal effects for children on their attachment, on their diurnal cortisol, on executive functioning, on language development even, with quite rigorous methodology ranging from observational measures to neurobiological stress hormone monitoring, and even brain imaging studies. And we really think that this work that Mary Dozier developed helps to support the theory that early adversity affects a wide range of systems, but can be buffered through parenting. And also, we also see that there are changes not only in the kids, but also in the parenting and in the parent themselves. So we definitely see that these studies demonstrate that there's increased sensitivity, there's decreased intrusiveness. Those are sort of the intermediary effects we believe to leading to then to the higher security of attachment. And all of these effects have been sustained years later through Mary's studies. She also finds evidence of changes in the parents themselves, such as in their brain activation when they're viewing children's emotional faces, demonstrating that they have a more awareness of and more sensitivity to children's emotions. So all this research by Dr. Dozier and her colleagues demonstrate just how well it works with the initial types of early adversity that she was interested in. And our work at Duke has explored other populations of risk, starting with from early attachment adversity and embedding it into specific home visiting programs, and then also trying to look at it in other settings with parents with other challenges, such as substance dependence or families experiencing homelessness. So I have 3 studies I'd like to tell you a little bit about today. The first 2 were conducted with Dr. Lisa Berlin, who's here in the room with us. She was at Duke, and I was a postdoc with her a few years ago. And now she, of course, is here at Maryland in the social work school. So what we wanted to do first was really to establish what would it look like? What is happening already in home visiting services? And is it working the way we want it to? So many home visiting programs, right, and sort of in the prevention of child maltreatment world, aim to focus on infant-parent relationships. They say that they're thinking about those things. Yet they're not always actually directly testing the effects and changes on attachment security per se. So in a study of 94 high-risk dyads who were already involved in the Healthy Families America weekly child maltreatment prevention home visiting program, Dr. Berlin, Dr. Ken Dodge, and other Duke colleagues and I tested this idea. So we measured attachment security and disorganization, and we tried to look at first toddler behavior challenges. And we did find that through looking to strange situations with these families, we found that attachment security and disorganization did predict the toddler behavior outcomes, just as one would expect developmentally. But interestingly, participation in the HFA program alone did not significantly affect their attachment security or attachment disorganization. The implications here are really that there's a potential for a deepening focus. There are many good things that are happening within Healthy Families programs, and we could be doing more. We could deepen the focus on attachment relationships per se by doing something like embedding ABC in those models. And so I actually was able to go on later to become the program director of that HFA program in Durham. And we did that. We did just that. We raised funds and brought ABC to the HFA program, and were able to think about when might families benefit from additional supports for their relationship. And we have been finding through our own observations that parents who get both models are really enhancing their parenting experiences. Then after that work, Lisa and I were also working and trying to think about ways to bring ABC into the world in North Carolina. And we conducted a pilot test for families who were living in a residential substance use facility with their infants. And so what we did, we wanted to really see, does it make a difference to implement ABC in those settings? We know that substance use is a child development risk factor. That probably has things to do with kids who are living in homes where there's substance use. The parents may be unavailable at the times when they are high or using. There may be a higher risk for them being exposed to other risk factors, other dangerous situations. Interestingly, when families arrive at residential settings, oftentimes those settings are really much more focused on the parent well-being and the parent substance, getting clean substance use, but not necessarily being able to leverage the potential benefit of working with parents and children together when they're in that setting. So that's what we tried to do. We tested using ABC and adding it to the residential service array at a certain location. So what we found after that study was that there was a difference in observed sensitive parenting. There was a trend towards significance with the mean differences between those and the families who had not received ABC being 3 times higher in sensitivity than those who had not received the model. So we thought that was a very positive change. So we also think that there's much more room. Whoa, here we go. That was not what I wanted you to do. Let's go back. There we go. Okay. So we really think there's some really nice implications for here how we can supplement substance abuse treatment with parenting expertise and support. So building on that work, I also became engaged and partnered with some colleagues at the Duke School of Nursing and Dr. Allison Eady, related to thinking about the adversity of homelessness in early childhood. So through this work, we received funding, and there were 3 different groups in Durham who were working with a center called Families Moving Forward in Durham. And we implemented 3 different interventions with them. I helped to support ABC. We also had families getting engaged in a Healthy Steps program in the Duke clinics. And then we also provided for the mothers health literacy program for those parents, really, again, sort of adding to the array of services that are available in a homeless shelter, because similarly, in a homeless shelter, families are often focused on employment and finding work and housing, right? So those are the things that they're mostly focused on. And we wanted to really build in, and this facility and also the families were very interested in adding on more trauma-informed work, as well as more family-focused work. So we were able to implement those things, and I'll tell you about the ABC changes. We did find significant changes in parental sensitivity, although there were no significant changes in other measures like parenting self-efficacy, so how strong, how confident parents felt about their own efficacy, or in child behavior problems. You can imagine that living in a homeless shelter or shelter for homeless families is quite a disruptive environment, and so that might also have to do a little bit with some of our non-significant findings. But we really felt like there was positive impact, positive feedback from the families regarding acceptability and feasibility. Although it was a challenging within that work environment, or the home environment for these families, when they were feeling like they were sort of they were in a fishbowl, and so their lives were pretty disrupted. Okay, let's try that. There we go. So this work, really thinking about how ABC can work in communities, also began to help us think about it, and our team really think about, how do we get this out to more people? How do we disseminate this model in a way that we can spread this model and others, and get the information out to communities and families. So what we know is that right now, evidence-based interventions are very limited in availability, particularly for early childhood, and that there's a lot of need from providers to have implementation supports to really understand how to go about doing it, how to go about doing and implementing an evidence-based practice in the real world. So when I was at the Center for Child and Family Health, we disseminate a number of multiple models using the National Center for Child Traumatic Stresses Learning Collaborative Model on the adoption and implementation of evidence-based treatments, or I'll just call them learning collaboratives from here on out, since that's such a long word. Okay. So when we think about trying to implement evidence-based models in a community, we know that the science gets stuck, right? So there's kind of the known research that shows that it takes 17 years from developing something to really getting it out and into everyday practice, right? So how do we speed up that process? What we know typically happens when a clinician who's very eager and excited to develop a new or use a new model, they go out. What do, right? They go out, they go to a 1 or 2 day workshop, they pick up a book or a manual, they go back to their office. What do? Put the manual on the shelf. Yes, put the manual on the shelf and start doing the thing. Maybe kind of doing the thing, maybe not kind of doing the thing. So typically that's what happens. But the question is, does that work when you are trying to apply it with clients? Generally speaking, no. Why is that, right? So it's because that training was focused on just that one individual, and that one individual resides within an organization that really needs to support them in order for them to do that work well. So what they can take back is really limited. Also, it's a point in time training. There's not sort of ongoing supports to help them with that. There aren't additional resources to help them learn how to do that. The other people at their agency haven't learned how to support them in doing that. Frequently, people don't practice skills during training, right? You listen and you stare at the person talking in the front of the room like we're doing here, but you're not actually practicing the skills. So that basically is kind of the only people who it might work for is the folks who already had a strong foundation, and then they can just add that into their framework. So we need to find a different way of doing this training. So this is what folks at the National Center have done to try to develop a way to integrate both clinical training and organizational support in order for this to work. So it was adapted from the IHI's Breakthrough Series model. And effectively tries to address both clinical and organizational capacities simultaneously. How does it work? There's many different steps involved. I'll tell you about a few of them and then show you a different image of this. So essentially, when folks are applying and want to come to a learning collaborative, they are carefully selected, right? So there's an assessment of your readiness as a clinician, your organization's readiness to do this work. And then those teams are a multi-level team is chosen, including both clinicians as well as supervisors and agency leaders, so that everyone is coming to get training in the model and training in how to go about doing this work. There's also a shared learning environment where folks come together to learn from each other. There's ongoing consultation, and then there's also measurement and metrics to ensure that we are really significantly and successfully adopting the best practice, including setting goals, establishing measures and metrics, and really monitoring how the work is going over time. This is a visual model of what the learning collaborative approach looks like and how it addresses these issues. So at the very beginning, when you're first developing a learning collaborative model, you will bring together experts in the EBP, in the evidence-based practice. You will also bring together experts in implementation, because those are two different fields, right? And try to figure out how hold an expert panel together to think about what's the best way to try to implement training on this model through a collaborative learning approach. And then you create your expert faculty team who is going to actually implement and train the model with folks. And then you begin to select your teams, again, thinking about what is the agency readiness, what is the staff readiness, and how do we pick these multi-level inclusive teams to come together. So that's where the agency teams are selected, and then they do some pre-work before they come together. Here in the middle is what we call our the learning sessions and the action periods. So we've got typically over the course of about a year, 18 months for some programs, 3 different learning sessions where folks are going to come together to learn together. At the beginning, maybe the first session is you're actually learning the model. At the second session, you've actually had an action period in between where you've been practicing that model. You can come back and be like, hey, wait, you said I was supposed to do it this way, but when I learn about this and when I actually do it in practice, it looks a little more like this. What are getting some higher level practice as you go through? And then session 3 is frequently focused on sustainability. How do we keep this going? In between, during those action periods, you've got your clinicians doing the work. You've got your clinicians are meeting weekly to really understand how to implement the model. They're meeting with other learners so that they're able to hear other people's experiences and stories, and they're meeting with the expert faculty to get feedback on that. At the same time, in separate meetings, the senior leaders and the clinical supervisors are meeting on a monthly basis to learn about what they need to learn about. Right. So what elevator speech are you using to sell ABC this week? Well, I'm using this. Oh, I never thought about doing that. I'll do that too. Or what are the issues that are coming up in supervision for you that we need to be thinking about? So that's a way that the whole system is being supported throughout this work. And then, as I mentioned before, we've got metrics being gathered to monitor the progress. How many clients are we bringing in? How many are turning over? How many are actually seeing it through the model? And what is the fidelity looking like in our clinicians or parent coaches? And with all of this work, the idea here is that we can then better sustain and spread the work. Take a quick sip. So now that you have an introduction to that model, what we essentially did with ABC was we decided that we wanted to implement ABC through both local and then statewide services. Following the earlier work that we had done with ABC and the training that I had received in it, I was invited by Dr. Dozier to become one of the first trainers outside of her lab to be able to train people in ABC. We secured funding from a variety of sources, including SAMHSA launch and IECMH grants and an ACF grant to really support this program over time. And since 2011, we have trained 154 different trainees. So it's about 104 parent coaches and 50 of those senior leaders through 8 different cohorts of ABC. And we've recently published a study that looked at a cohort of those trainees, including 18 trainees and 67 families, looking at training outcomes and intervention outcomes. What do we see in terms of the training outcomes? Training completion was reasonably high for a model that is this complicated and for an intense training model that it's also, you have to stay with it for the whole year. And so about 72% of our folks made it all the way through. Interestingly, when we looked a little bit deeper into the model, or into the data, we found that actually the location or the venue of where you work tended to be related to whether or not you were able to continue. So we had a couple of folks had great ideas in North Carolina to get child welfare workers themselves, right? So sort of frontline people who are child protective services or DSS workers to be ABC providers. Great idea. And they have so many competing needs that they were not able to actually stick with the model. So we're still working to figure out what can be the best way that we can still get that service to kids who are in those child welfare settings. The parent coaches loved the work. They wanted to do more of it. And then they also had their phone ringing in the middle of the night to go pick up another kid, right? So they couldn't do some of that work. So that was positive. The training completion rates were high. Also, in terms of training effectiveness, all of the trainees met the model fidelity requirements, and training satisfaction was very high in terms of both the 3 days of training where they came to work with us. They felt that things were, relevant, engaging, informative. And what they also really loved was the real-time practice. The consultation, weekly consultation, was really helpful for them to be able to learn the model most effectively, and connection with other trainees. I'm going to come back to that in another story about a learning collaborative in just a few minutes. But that connection and building that community really matters when you're doing this work in early childhood. In terms of the intervention outcomes, we started to look, particularly wanted to kind of replicate some of the findings that Dr. Dozier had in terms of observed parenting. So we used the same measures that she uses to look at observed parenting, and we did find that parents were significantly more likely to show increased sensitivity, higher sensitivity, and lower intrusiveness compared to folks who were actually just over time, sorry, it's compared to themselves from the beginning to the end. And then also, we found that we wanted to do, in addition to doing those observational measures, we know that community practitioners are not always going to be able to go to really training to be able to learn how to code some videos, right? So they need a quick snapshot of what helps families so that they can measure those things for their own needs. And so we also tried to implement more quicker measures that community agencies would be able to use. So we use something called the Infant Crying Questionnaire, which is essentially a self-report measure of parents saying what I feel like and how I act with my child when they cry. And we found some really interesting positive changes from pre to post. So one, parents were more likely to say that when their child cries, they feel the need to respond in a way that that child can feel more secure and that they can calm them. They also were more likely to respond at the end than the beginning, that they felt like crying is a form of communication, that this is something that their child is trying to tell them, so that therefore they need to respond. And then the next two, I think, are also very interesting in terms of minimization and spoiling. So by the end of the training, we found that parents were more likely to say that they did not minimize their child's needs, and they also didn't believe that when they responded to their child, that would be spoiling them, right? So this is a really positive direction that we're seeing these families go in, of being able to. It really explains, I think, why we see this higher sensitivity, maybe because of the way they're thinking about their parenting and thinking about their child. They also were more likely to report parental self-efficacy. So we didn't find that right in the model with the families in homeless shelters, but in this training effort, we did find that parents felt much more confident in their capacity as parents. And we also found significant changes from the children in pre to post in terms of their social emotional development using the Devereaux Early Childhood Assessment. So factors like self-regulation or initiative or attachment relationships these are the kinds of things that if we're seeing kids go in this right direction, then we're really building some protective factors for them. So in sum, I really feel like we've learned from these interventions that they can be applied in community settings, and there are similar outcomes to those that we find in RCTs, and that trainees and agencies respond positively to using this learning collaborative model. I think that this work ties nicely to a lot of the things that you all have going on here in Boston, including that Dr. Berlin is here now and implementing ABC here. Also know that lots of folks are doing other models such as attachment vitamins or child-parent psychotherapy or mom power, lots of things going on here. And I think this is just a great evidence for the idea that we need this work in our communities. But in parallel with this work on learning collaboratives for interventions, we also began to learn more about what the workforce needed, not only just in terms of their interventions, but what else do they need to be able to meet the needs of young children in their communities. We pursued a number of funding sources, and in 2022, we were awarded a SAMHSA Early Childhood Mental Health grant to increase access to services for young children, specifically by centering the needs of the workforce. That was the primary thing of what we did. So we had a variety of activities that we did statewide, from just kind of your basic infant mental health training to what is it, is it just putting a baby on a couch? What are we talking about? But we also tried to, we did that at some level for some providers, but we also did much deeper learning collaboratives. We did 2 ABC learning collaboratives, child-parent psychotherapy and parent-child interaction therapy. But today, what I want to focus on is this aspect, which I find really important, which is thinking about how we assess and diagnose young children related to their developmental needs. So we know that early childhood is a critical period of brain development. We also know that children in this age group are at the most at risk for maltreatment and for involvement with child welfare. We also know that young children have similar rates of mental health disorders as do older children, and yet they're not getting the services that they need. So young children rarely receive treatment for those disorders, and there are disproportionate delays in getting those treatments or assessments for Black and brown children. We also know that one of the reasons for that is that the workforce is not prepared for that. They don't know what to do. We did a survey of over 100 clinicians across North Carolina in 2020, and they told us that less than 20% of them had been trained on anything that to do with the early childhood diagnosis. So they weren't really sure how to go about, how does it look different from older children? So we can't necessarily apply the same tool with young children. And 90% of them said that they thought that having a training in this would be really important to them. So we did that. So we tried to develop a learning community around this. Screening and assessment and diagnosis in early childhood, as many people, and I'm preaching to the choir here, I know many people in this room would know, it's a complex skill. It requires being able to think about what do mental health challenges look like in a young child? How do they differ developmentally from older children? What kinds of things, how do I look at a relationship in early childhood, right? Because when you're thinking about an older child versus a younger child, the context of the relationship is where the action is. So you really have to also be assessing relationships in order for kids to be able to get the services that they need. And also thinking about how we utilize both developmentally appropriate, but also culturally responsive work across all areas of assessment. So what did we do? We did a 2-step model, basically. So we started off with some foundational diagnostic training, building myself and 2 other trainers in Durham have the capacity to be able to train in 0 to 3's diagnostic classification of mental health and developmental disorders of infancy and early childhood, or DC 0 to 5. Why do we have so many long phrases in our academic world? Anyway, DC 0 to 5. So we start with a foundational training so that people understand just what the diagnoses are. This is the first system for diagnosing early childhood mental health disorders, and it really is an approach that centers culture and centers the role of developmentally sensitive and relationship-based work. So that's where we start. And then to beyond that, right, you can come again, we don't want people to walk away with this manual of like, these are the disorders that I need to know, but how do I get to that? How do I figure out what that looks like? So we then developed a skills-based training using that collaborative model to help them get a guidance on how to get to and access those diagnoses. So our learning collaborative approach, or learning community approach, effectively was a 4-day session where we looked at the foundations of assessment, how to conduct an interview, how to do a standardized, what are the standardized measures I should be using, how to go about using them, what are the observations I should do to look at relationships, both structured and unstructured, We watched videos of those. We talked about those. We were able to think about those kinds of things with them. Then we also tried to focus on how do you integrate those findings from a cultural perspective, using clinical formulation, and then what do you do with that information once it's collected and integrated? How do you communicate back to a family information that might be very hard to hear in early childhood? In addition to these 4 days of training, we conducted 6 months of consultation with one group call per month in small groups. And so the clinicians would come together. Each of them would present a case, and then they would be able to get feedback on their case and how that went, co-facilitated by our learning community faculty. And then they also could get one individual consultation, like perhaps they were writing up an assessment and they wanted to know how to go about phrasing this or something like that. We could also do that with them. So we conducted surveys and interviews at 4 different time points after during and after the training. So we did one immediately following the 4-day training, then we did another right after the 6 months of consultation, and then we did another follow-up survey 6 months after that, and also included in that post 6 month assessment, we also included selected interviews of some of those folks. Given the time constraints, I won't be able to go into all of these. I'll just talk about 2 sources of data. First being the end of collaborative survey, when we looked at sort of what were their skills pre and post the collaborative, what did they get out of the collaborative, and what are their thoughts about the training. And then finally, at the selected interviews, 6 months after the collaborative was over, how are they doing in using the models or using the assessments, and sort of a deeper dive into the training and consultation model. So in our end of collaborative survey, we were able to find that they had measurable gains in their skills, as you can see here in these slides, or in the slide. The knowledgeable gains included, those are pretty tiny words, things like increased knowledge about treatment recommendations, how to go about assessing young children, how to integrate that data into a really nice, tight clinical story, how to articulate the rationale for a disorder for a young child, right? There's some debate for many about, like, how do I go about ahead and set a diagnosis? Am I causing a challenge for this child down the road? Am I setting a path for them? Really thinking about those things. When is it best to do that? When is it not? And also how to make sure they're identifying sociocultural issues that might be related to the diagnosis. In terms of their readiness, the trainees felt overall very confident in their readiness to be able to implement the different pieces of the assessment elements, like selecting the tools or interpreting the measures or observing families and figuring some of those things out. And then finally, they had a very high level on a 5-point scale of the knowledge and support from the trainers. They felt that they were well prepared and could really help a lot with specific case examples. Then after the 6 months had gone by, we brought some back for an interview, 12 folks back for an interview to think about what were the valuable components of the community. And folks really felt like their exposure to a variety of measures, having a shared language around communicating about the assessment was important to them. And then mostly learning from their peers and building relationships. We had some great stories, as you can see in this quote here from one of the folks about that they built relationships with others in the collaborative. Early childhood mental health is a pretty small field, and so you can feel pretty alone if you're out there in a county in the middle of North Carolina and you don't have anybody else to do it. Now they had someone to pick up the phone and call and ask and get some support from just from other peers. Not even that they were calling us as the trainers, but they were calling each other to help with those issues when they needed it. I do want to pause here to share with you, this is something that came out of our work. We developed a compendium of many of the infant and early childhood measures that we could find, in which it really includes sort of the psychometrics, how to go about using the measures, who have they been tested with or sampled on. You can find that here for yourself to download if it would be useful in your work. We really have the goal of spreading this awareness and knowledge. Okay. So next, I want to talk a little bit about my work since I've found myself and transitioning over to the National Center for Child Traumatic Stress. So this is just one piece of our very broad scope. And I really am, but I'm really trying to figure out ways to continue working towards supporting the early childhood workforce and children and families. So if you're not familiar with us, just to tell you a little bit about us, the National Child Traumatic Stress Network is a federal initiative established in 2000 through the Children's Health Act from Congress. And it is a program that is administered by SAMHSA and coordinated by the UCLA Duke National Center for Child Traumatic Stress. So it's a co-located national center. This network includes child-serving professionals and caregivers and researchers and young adults and national partners working all around the country in 48 different states and the District of Columbia, Puerto Rico, and Guam. The initiative has maintained continuous funding and bipartisan support for more than 2 decades. And most recently through our reauthorized funding in 2020, in fiscal year 2026 of $100.887 million. A little bit of us by the numbers. We have currently 193 funded centers, including the National Center, across the country with more than 200 formally funded sites or affiliate sites and individual members who also join along in this work with us. Each quarter, more than 87,000 people are trained by, and more than 116,000 people receive services from agencies that are receiving NCTSN funding. Together, these sites function really as a national infrastructure, not simply a collection of grants. Across communities, they're really working together to build trauma-informed communities through direct treatment, through workforce training and consultation, and through community education. The network also has the capacity to mobilize in times of crisis and disaster to respond and provide support to communities. Tying it to or kind of narrowing the focus to our early childhood services, for 25 years, the NCTSN has been really a foundational part of the nation's early relational health framework. Numerous NCTSN sites focus purely on early childhood with the goal of early access to families and children to support healthy development and help kids thrive. To illustrate a little bit about what that looks like in practice, I'll briefly share 2 early childhood examples, one from workforce development and one from direct evidence-based services. So across the country, we've been partnering with child parent psychotherapy or CPP trainers as well as providers. And we've been working recently with them to help them conduct treatment through virtually. One can imagine why that's important to have telehealth in these times. One of our resources, which was a webinar that was released last spring, there were 300 people in the room for the webinar. That was the maximum that was allowed in our Zoom room. And then after that, it's been released now on the web, and 3,300 people have viewed it. So we find this is really important. Yeah, thank you. We think this is really important because now these clinicians are trained in some skills that they can actually use on the ground, which translates to greater capacity to help kids. With this increased capacity, what are we doing in terms of evidence-based services? Children are receiving direct services that support their recovery in their own communities throughout the network. For example, one site shared a story with us about a young boy who was attending a childcare, a preschool setting, and he came into that preschool setting just a few months after the devastating loss of his father. Initial transition was really challenging for him and for his mom and for his teachers. He was really deeply withdrawn. He was silent in the program, wasn't engaging with other peers. And he was really just struggling to adjust to a new environment while also trying to process his grief. What we found is or what that site found through a combined set of resources, they engaged him in the family in child parent psychotherapy, as well as in therapeutic interagency preschool. He is now blossoming. So he is now speaking, he is now engaging with other peers and having fun and steadily meeting his developmental and emotional goals. So I think that his transformation is really just a powerful reminder of resilience when kids are able to get the right supports at the right time. But these sites do not operate in collaboration. Yes, they do. Let me try that again. They do not operate in isolation. They operate in collaboration. A couple of examples of how our network is working to do that. We host a dedicated early childhood collaborative group, of which there are members in this room. we really meet monthly to share tools and share resources and implementation strategies. Really think about the ways that we can help families. There's about 20 people per call, but the calls vary in who sits in the room based on what the interest and the topic is. And there's also 279 folks on our listserv, and they're using that listserv very frequently for resource sharing and collaboration, just finding the ways that we can help each other out in these times. So the group meetings recently have been doing what we call baby talks, where individual members from the network will come and share something about a strategy that they are using in their community. And so that's important for them to be able to share how they're using their work, but it's also a space of collective wisdom. So other folks can learn from that, can begin to think about how can I, and reflect on after the talk, reflect on how can I implement something like that within my community, or what is my community doing that could help speak to what you're doing. Lots of ways of sharing collective wisdom with one another. Recent topics might have included things like policy, like how do we translate a recent research article that came out on CPP. We talked about how to translate that to talking with policy people about how important that work is and how early childhood mental health makes a difference. Also think about implementation and research collaboration issues with various models like CPP, like PCIT, like mothering from the inside out. And then also some sessions have focused on what is the role of reflective consultation and supervision that I can receive as a provider across my lifespan. When do I need it? What does it look like? And then in addition to these really kind of directed topical calls, we also just have open reflective spaces for being able to talk about things. And so, for example, a recent example was when we had the very brief defunding of the entire network for about 24 hours in January, when all the SAMHSA discretionary grants went away. This is one of the groups that came together and really thought about what that meant for them. Even when we got the funding back, how did that impact their community? What are they doing to try to think about and work on the workload and burnout? Okay. I also had a research example, but I think in the interest of time, I'm going to tell you the short version of this, which is this is work that I did with Dr. Briggs King here in the audience. This is evidence from we have a collaborative network, including the research that we have. We have data that was collected from all of the different sites for a long period of time. And Dr. Briggs King was the director of the data program for many years and would have lots to share about that. What I will just tell you in terms of a short story about this is that we are really interested in understanding early childhood bereavement and how it is one of the most distressing among all traumas. But again, young children are not receiving the treatment. And we were able to look at this issue and try to think about the ways in which children were affected by the traumas of losing a parent or loved one, and we essentially were able to find that one of the things that was a key factor is that the relationships to the deceased, so whether it was a parent or sibling versus another close relative, was very highly predictive of their traumatic grief. And that's an area, but not necessarily of several other areas we're looking at, like post-traumatic stress symptoms or attachment problems or internalizing or externalizing problems. So we think this is an interesting area for us to be thinking about in terms of when we're working with young children after a death or loss, ways that we can be ensuring that we're assessing and thinking about their traumatic grief challenges. Okay, so in conclusion, we know that early childhood adversity and trauma have significant impacts affecting attachment and psychosocial development and emotion regulation, and that there are evidence-based interventions that can help. We know that early childhood assessment and diagnosis is essential for accurately identifying challenges and getting kids down the right path. That the learning collaborative model can be effective in increasing the spread of early childhood assessment and services, and that the National Child Traumatic Stress Network offers collaborative supports and resources that can be helpful for the workforce as well as for families across the nation. In closing, I hope that you have been able to see how I think that these examples are illustrative of the ways that we can work together to continue to help families to find that foothold and stand with dignity. And I'm eager to take the last few minutes to think with you about how this presentation connects with your work here in Baltimore or at the university. Yeah, should I stop screen sharing? I guess I'll leave it up.
Hello, thank you for a wonderful talk. I was curious your big picture view on thinking about what needs to happen to improve policy and practice around two quality of care issues for very young children. The first is telehealth. So providers who are billing for virtual behavioral care without sort of standards that are appropriate for very young children, especially with trauma, who are difficult to engage. And then the other is about medication treatment of behavioral disorders. So it's great to have these different psychosocial treatments and to try to build up the workforce and disseminate. But we know that the care that's going on now obviously doesn't meet what we would think of probably as quality of standards in those two areas. So I just, your thoughts about what needs to happen to improve care from those, two domains.
Aspects, yeah. Thank you for that question. I think that in terms of telehealth, I think there's been a lot of progress and a lot of folks working in that area to think about how we can reach young children. And even as you're saying, we can't necessarily keep them on the screen, right? So even with ABC, which is a model in which we're video recording the families at all times, you sometimes have to be able to move with the child. So I think that's one element in terms of telehealth that would be important, would be to figure out how to advise and support the families to be able to help with them with their family, right? So to be able to move with the development of the child, recognize that you're not necessarily going to be all in one place at the entire session, right? Where you might be able to ask a 10-year-old to sit still, maybe. So that's certainly one element. And then in terms of that, like in terms of best practices for that, I think we also need more guidance and understanding about how that's going to look from a billing perspective. Like how can we ensure that we can receive the full amount of reimbursement for that type of service. And then your second question was about medications. I mean, maybe this is a simplistic answer, but I think that especially for very young children, I think additional psychoeducation with families about when it's needed, what are alternatives, but working closely with a team. Kay and I were talking this morning about sort of the role of interdisciplinary teams and how we can ensure that there are lots of things happening for that child. So we're not just thinking about only sending an infant or young toddler for just the medication treatment, but also being able to think about what are the wraparound supports that are actually going to be making a difference, and how can we ensure that those supports are addressed to be able to handle that. Yeah.
Question?
Thank you so much for your talk. Can you speak a bit to public funding for ABC and whether you all have been able to leverage that? I know in Maryland, I think if we were able to at least have some public funding, then we might be better able to leverage private funding.
So there are some agencies in North Carolina that have figured out ways to bill for services for kids under 3 or 5, that can be challenging in a variety of different communities. But there are some folks who are figuring out those ways. I think working closely with Medicaid offices to really be able to support the need for that dyadic type of work is one really important element. What we have mostly found, though, is that that's not, even if you could be able to bill for those services for ABC. ABC being a home-based intervention is much more than the 50 minutes you're sitting in the room with them, right? There's the 20 minutes you got to drive there, maybe an hour you got to drive there. There's all that time back. There's the time that you're watching the videos afterwards. There's the time that you're clipping and cutting the videos to work with the family the following week. So we have really found that it's probably going to have to be a braided source of funding. And in terms of public funding, there have been some funds in North Carolina where we are able to get sort of state funds through grant programs to really look, especially funds that are related to sort of child maltreatment prevention. So those kinds of fundings that might be coming down from the federal government but delivered through the states. Those can be ways that have been helpful to sort of round out the funding for that. Yeah. Good question.
I just want to thank you so much, Dr. Carmody, for really talking about all my favorite things. I feel so grateful. Yeah, well, it felt like it. So thank you. I feel so grateful to the National Child Traumatic Stress Network and all my incredible colleagues that I've met across the years. And we've really tried to sustain what we've learned. And we're an affiliate site now and, bring all those lessons to our work. So thank you so much. Yeah. So the last couple minutes of our time together in this room is, thank you, is a chance to honor another one of the founders of our program, Alma Trockley. Alma was the business manager, and she worked closely with Dr. Matarasi to sustain this center all these years. And it's really because of her tenacity and hard work and truly just big-heartedness, as well as being quite smart with numbers. We really have been able to, we're able to be here today to keep the work going. So when Alma retired, we started an annual recognition of all that she did for the center. And each year we award an outstanding community member who's really made a really big difference in the field and really more directly in the lives of children and families. And this year, I'm really excited to introduce the award winner. This is someone who we've been partnering with, is really becoming a critical partner in many of our grants and efforts. And she actually doesn't know that she's winning this award. So this is a big surprise for Renee. So she was looking at her phone. She had no idea. Renee Everett Savone. So excited to give you this award this year and to honor you for all that you do for children and family. Renee is the executive director of the Parents Place of Maryland, and she's been leading amazing efforts for our state. And kind of one of the core things that the center does, or the Parents Place of Maryland does, is to provide peer-to-peer support. Families that have lived experience of raising children with mental health needs or developmental needs, helping them navigate still, unfortunately, a very fractured system of care. And they're really the experts, right? And they really give parents the confidence to hang in there, to navigate different situations, and to really be able to show up as partners in their children's education plans or treatment plans. And so we're very excited to give you this award this year. We love it when we can give a surprise.
I'm thoroughly surprised, and my goodness gracious, I didn't even know that. All right, okay. I have team members that are here that I didn't even know were here. Okay, y'all are going to get it later. And just thank you. This just thank you. It means so much for not about me, but just the fact that the work of our organization is acknowledged, and what a game changer it makes in a family's life when they get connected with us super, super, super early. And I couldn't do this work without my amazing team. And oh my gosh, my wife is in so much trouble too. So anyways, thank you, because I'm standing between you and food. Thanks.
And thank you, Brooke, for helping us pull off this big surprise. So we actually, the food did get delivered right out here, so that'll make life easy. And anyone who can stay for our advisory board meeting, it's going to be on the 3rd floor, and we'll be gathering you if you can come. So thank you, everyone.